basically shows us what are the different things we look at in different modalities. And it's a pretty busy slide, but I will just try to focus on the echo part of it. And what is the advantage of echo over CT and MRI is the portability, the cost effectiveness, and ability to get a lot of hemodynamic information at bedside, which is sometimes very important. And again, very safe for the patients because we don't use any contrast agents or there is no radiation. This slide shows the advantage that I mentioned about. Certainly, CT and MR have an increasing role, particularly when we get into the constrictive physiology when we are looking for myocardial thickness. More importantly, echo is sometimes limited by the field of view. So depending on our windows, and even if we have good windows, we do still have a more restricted field of view as compared to CT and MR. Yet it is very advantageous, as I mentioned, low cost, a quick exam, ability to do it bedside, and easy to monitor patient during the study. Obviously, as this shows that you can have the pericardial thickness, calcifications better seen with CT, thickness also with MR. Inflammation is best seen with the MR, and detection of effusion, I think echo is pretty good. Again, we are limited by the field of view, so sometimes if you have loculated effusions and they're hiding behind, say, the atrium, sometimes you don't get as good a view. But what echo offers additionally and MR too is the cardiac function, the diastolic dysfunction, the septal motion, and the respiratory variations. So as I mentioned, these are the diseases that we normally deal with, the effusion, the tamponades, the pericarditis. There is a role of echo and the constrictive pericarditis and pericardial tumors and cysts. The commonest etiology of pericarditis, are infection, maybe viral sometimes. These are the common ones. Post-surgery is very commonly seen in the hospital settings, post-MI, uremic pericarditis related to collagen vascular disease. Less commonly in our setting are the malignant effusions. You will see that more in some place like MD Anderson where they see a lot more cancer. And then, of course, traumatic and post-procedurals. So, in pericarditis also there is a role of echo. And one is you need 2 out of the 4 criteria listed to make the diagnosis. Obviously, symptoms, EKG changes, presence of new or worsening pericardial effusion, and the pericardial rubs. Then you have the markers of inflammation that are listed. And now we have the pericarditis divided between acute, incessant, recurrent, and chronic. That is not what I'm going to focus most of the talk on, so I'm going to slip through all this really quick because all this shows is the class 1 indication of echo in setting of pericarditis that is present, there is treatment, and then when do further imaging becomes necessary. Again, which are the pericarditis that we worry about and which are at risk for causing possible constriction? And those are usually related, very less common with viral pericarditis, but it is very much more common with bacterial pericarditis and somewhere in between with autoimmune diseases. So again, etiology is important. And I'm going to go through all this because that's more of the clinical standpoint. And these are some of the issues that have an advantage, the MRI and the CT. Calcification is very well seen on CT. The extent of calcification is very well seen on CT. But MRI is very important, especially the late enhanced gadolinium for the identification of inflammation of the pericardium. So now you have patients with an echo, has symptoms. Echo may or may not show a lot of effusion. Obviously, pericardial thickening is very difficult to pick up on echo. That's when MR has a very important role, and Dr. Nabi will talk more about it. Again, CT is limited because small effusions and thickening, it cannot differentiate as well as the MR. I'm going to go through this because that's not my area, and I'll go through this. So I think from an echo standpoint, it is very important to know how to define an effusion. It is very clear when it's an obvious effusion, but sometimes we have normal echolucent areas, particularly when you are starting off in the field of echocardiography, that you need to know. It is very important to know what is normal to be able to tell what is abnormal. So echolucency is how we define an area of pericardial effusion, location, being able to distinguish between pleural and mediastinal collections, and as I mentioned, what are the normal echolucent structures that we can see. So let me see if I can play these. So this is a normal parasternal long axis view that we would take. And you see you have to have the depth changes because you want to be able to see the pericardium and the pleural space. If you're very much zoomed in, you're not going to be able to delineate the pleural space, and therefore you won't be able to see if this is a pericardial or pleural effusion. This is a perfect example of how a both concomitant pericardial effusion and a pleural effusion. And as you can see, this is the pleural effusion here, and the thin linear here is the pericardium. So when you see something like this, it's very easy because both of them are present together. But what if you just had one of them? One of the hallmarks of a pericardial effusion is the fact that it ends just before the descending thoracic aorta. So this is your aorta here, and you have your pericardial effusion ending here. This echolucency is your pericardial effusion, and this echolucency is your pleural effusion, which extends all the way up here. Again, in short axis, one of the things we look for is, does the echolucency follow the cardiac silhouette? So you want to be able to see it hugging the left ventricle and the right ventricle around it, because that's where the pericardium is. This again is a pleural effusion because it does not follow through. This is your pericardium here. And somebody wants to take this. What is this echolucent structure here, and what is this here? Who wants to take? Alkna? This one? So tell me, what are you seeing here? This. Yes, that's the descending aorta. So what you're seeing here is the aorta. Again, as you can see, this going away from the cardiac silhouette. There's a little bit of pleural effusion, and then there's the pericardium here. So you have to be able to tell that. So these are what, and then of course this shows the very important structure that we all deal with, and is this the epicardial fat pad here? And that's what it looks like, okay? So sometimes you may have a very thick epicardial fat pad. Now remember, clinical history is also important. If the patient has had surgery and you see such kind of echogenicity extending all the way out, it could be a mediastinal collection too. So these were the normal things that you look for. So now let's get on to the cases. So this is again the first case where a patient is post-op, and you see a post-cardiac surgery patient, bypass, and you're seeing you have a routine echo done. A patient may be short of breath. You're looking at this, and you see, okay, this is very clear. You see how nicely hugging. You have an anterior effusion. You have a posterior effusion ending right before the descending aorta. Again, beautifully following the cardiac silhouette, as I had mentioned in the parasternal short axis view. And this, of course, is our, the one thing I want you to notice is that everything is not mutually exclusive. So you can have effusive constrictive physiology too. You can see a very nice septal bounce here. You can see your Doppler data showing that with inspiration at mitral inflow, you have decreased in the velocities, and then as it increases with expiration. And you all know how to calculate the difference that we look for. We look for more than 25%. Again, you're seeing a little bit of a septal bounce here. So this is a patient who has effusive constrictive physiology. The second case was also, who is again patient post surgery, and you see classic what are you seeing here? Okay, come on, play. So you can see that you're seeing, if I play it, you can see the RV here. There's a collection here. There's nothing posteriorly much to speak of. And your eye, if you're trained, you can see there's something abnormal with the version of the RV free wall. And what you're seeing very beautifully demonstrated by an M mode. So why is M mode superior sometimes just to our visual subjective assessment? It gives you a really good objective assessment of how beautifully the RV is collapsing in diastole. You see this? That's your RV free wall, diastolic phase, total collapse and coming out. Again, viewed beautifully in this view, which is your parasternal little off-axis RV inflow view. Again, multiple views demonstrating this. Again, this is the RV OT. Remember, sometimes you may not see RV free wall collapse, but you may see RV OT collapse. And that is because it is a very thin wall, thin pressured segment. So you will easily see it collapse. So these views are very important from a sonographer standpoint. Again, this is your subcostal view, and that's showing you how nicely the RV is collapsing. Again, the M mode of the same. So I cannot emphasize enough how important M mode is. Something very obvious that your eye can pick up, a subtle motion may not be able to be discerned by an eye, and that's where the M mode helps you more. This is the case where we had a 14-year-old male transferred from MD Anderson. He had been diagnosed with acute leukocytic leukemia, had undergone a bone marrow transplant, was very hemodynamically unstable, and he was transferred here. And you can see, who wants to take this? Jeff? So what do you see here in this view?
I mean, there's something ecolucent that I can't really see it, to
Is
be
it
honest.
this? When you say ecolucent, what are you indicating? This? Where?
I was talking, I guess, anterior, yeah. There.
Yes.
That's compressing the RV, but
So this, I wouldn't describe it as ecolucent, would you?
Well,
it's not, right?
No, it just shouldn't be there.
So there's a yes. So this is what a potential mass or a blood clot would look like, right? It's not going to be very ecolucent. You're going to have an echogenicity to it. But what is very striking is that if I had to describe it in layman's term, the RV is struggling to stand up. RV just seems not to be able to get its head up, butting its head on a ceiling kind of deal. And you see that beautifully here too. I wanted this M mode was put because I wanted to demonstrate how sometimes this patient is very tachycardic, yet we don't have a good EKG tracing here. And you can, however, correlate with the mitral valve opening to see if you're seeing any RV diastolic collapse. And here in diastole, you can see that it comes in, but it is not just slamming in as it was in the previous tamponade that I showed you. Yet this patient was extremely unstable, very tachycardic, hypotensive. Again, another view showing this, again showing you that in real world, we have to take multiple views, and that is the limitation of echo. Your windows have to be adjusted. Here we hardly see the RV. You feel there is some collection here too. In the subcostal view, beautifully you can see there is a huge collection anterior to the RV. Importantly, you're not seeing a whole lot of variation here. Again, we don't have a respirometer. You don't have enough sampling. So this is not, again, a well done from Doppler standpoint. Then the contrast was given, and this I don't think would have changed what I had. You already know there is a mass or a hematoma around. What it does, however, demonstrate is the contrast uptake. So there could be two things. It could be a very vascular tumor that you're seeing there, or you're actively bleeding into the pericardial space, and that patient would be extremely unstable. This patient did have a mass, very poor prognosis. They tried to evacuate it, and he died third day post-op. These are the kind of cases. The next case is what we see more often. And I go through cases because I want you to show how everything is an evolution. And so A lot of times when we are in the echo lab and patients has had an echo 2 days ago, and you say, why does the patient need an echo again? Well, this case demonstrates that when patient is hemodynamically stable, how quickly things change. So 52-year-old gentleman who had undergone an aortic valve replacement bioprosthetic on the 5th of July and comes in with fever, increased blood pressure, tachycardia, just looking pretty ill. And this was the echo that was done on admission, and they feel, you can see again beautifully, there is a pericardial effusion collection around the, which you would probably describe as moderate. Patient underwent pericardiocentesis. He was staph positive. Because he was staph positive, he underwent a TE to look at the valve. And this was the valve that they saw. Unfortunately, this cursor is going through here, but there is this little echo haziness here. Do you guys see it? Now, you wonder when you see something like that, is that a vegetation? Could it be a vegetation? The color Doppler did not show the valve to be unstable. I think this is a better view. So you can see it here, yeah? That there may be something like a vegetation here. And that's your color Doppler. Okay, so it was, okay, they treated him for endocarditis. This was 2 days later, the patient acutely decompensates, hypotensive, goes into cardiogenic shock. They had to resuscitate him. He gets a T, transthoracic and a T immediately in sequence, and this is what you see. Somebody take this. I'm going to, since you want to take that, I'm sorry, yes, you. I'm sorry, I'm not familiar. What do you see? So this is 2 days after the first one. Should I point and ask you what you're seeing, or you want to tell me just what you're seeing?
There is an echogenic in the area in the posterior pericardial space that seems to be maybe bleeding.
Again,
it's not completely ecolucent.
So again, a very echogenic collection posterior to the, possibly to the base of the heart and LA. You are hardly seeing the LA. Descending thoracic aorta again, so indicating it's in the pericardial space. Now remember, this patient had a pericardial effusion that was removed. So you're thinking, could something be going on there? Then this is the next one. A subcostal view. Again, you can see that there is some collection here and here. This patient underwent TE, and this is what it looks like. So this is your, I guess, 4-chamber view with huge hematomas around both the atrium that are completely compressing the atrium. Patient was emergently taken to the OR and evacuated, and this is what you see now, okay? This patient actually had dehiscence of his aortic valve sutures and bled into the pericardium. He still continued, they cleaned it up, they resutured it, and he still has this what looks like to me like a vegetation, but his course was good, complete recovery. So again, this is when you'll say, oh, patient has had an echo T, why are we doing it again? Well, that's the reason. Yes. Do you want me to go back?
Would you agree, is this LV collapse?
This one? Yeah. You raise a good point. You can see it's going there. To be honestly, I can't see it. So an M mode would have helped. I have a case, and I'll show you later. I mean, this guy was crapping out, so they had a lot of reason. This is, next case will show you the importance of understanding the interplay of the pericardial pressures and the intracardiac pressures. And this will demonstrate that. So this was a 50-odd-year-old woman with history of being very short of breath prior to admission, comes in with hemodynamic instability, increased heart rate, low blood pressure, just not looking good, and the echo was done. Who wants to take this? Volunteer, somebody raise their hand. Okay, the senior fellow.
So there looks like predominantly posterior posterolateral pericardial effusion, which seems to be creating some diastolic LV tamponade. The LV cavity is small, the RV is massively dilated, the septum is flattened.
And that's exactly what it is. So the M mode here shows beautifully, and I think I can show it here, the LV wall coming in diastole, your diastole phase, and this is a LV diastolic collapse. As you can see, this is what, this patient has history of pulmonary hypertension, very high pulmonary pressures. There's a collection, you can see in the anterior too, this patient has pericardial effusion. But the chamber that is being most affected, and you can see it here also towards the apex here, is the LV and not the RV that we traditionally expect, because look at how high the PA pressures are. This is 64 and plus, you have the respiratory variation. So this shows the importance of understanding that traditionally we expect the low chamber pressures to collapse first, and that would be expected, but two things decide. One is how high the pressures are in the chambers, and where is the effusion located. So you can have a loculated effusion causing a very localized compression of the chamber. And so you have, this is your mitral inflow here. We don't have a respirometer here, but you can see definitely there is significant variation noted. And it actually follows almost a breathing pattern here. So the last case for this pericardial effusion tamponade is, again, emphasizing how this is beautiful. I'll go through it quickly in interest of time, but you can see this is the RV diastolic collapse. There's a very small localized effusion anteriorly to the RV, and you see the RV collapse. So one of the things you will see humongous uremic pericardial effusions, and there is no tamponade noted, and that is because this accumulation has occurred over the time. Pericardium is very compliant, so it's able to withstand the pressures. Acute collection of pressures with collection of fluid within the pericardium, which is very inelastic, can give very fast rise to the pericardial pressure, intrapericardial pressures, and caused tamponade. And this is a patient who had come in with acute chest pain, and I'll play this. And to be honest, if you're playing this, you really have to look very carefully. This is your, they're trying to image the descending thoracic aorta, aortic arch. The next view shows it pretty well. There's a nice flap here. So the patient had aortic dissection. So another thing to look for when patient is hemodynamically stable, aortic dissection related pericardial collection and tamponade. So in most cases, transthoracic echo T, depending if patient is post-op and if it's a loculated effusion, these two are, for tamponade physiology, we don't need any more imaging modality. And again, echo remains the best option because in an acutely hemodynamically unstable patient, ability to do it bedside quickly and have good monitoring, echo remains the modality of choice. I'm going to quick through this. So going quickly to constrictive pericarditis, it's a diastolic abnormality. I think one thing to understand about constriction is that it is like your heart is stuck in a cement. It is a very rigid pericardium that encases the heart, and therefore you have the hemodynamic profile that we see with constrictive pericarditis. You have ventricular interdependence, so RV and LV kind of function reciprocal to each other. There's loss of transmission of the intrathoracic pressures. What does that mean? That with inspiration, when there is decrease in the pulmonary venous flow pressure, the LA still has very high pressures, as does the LV EDP. So you have loss of transmission. That's why with inspiration, you have decrease in your transmitral flow. And with expiration, you have it reciprocal. There is equalization of end diastolic pressure. You see the classic dip plateau on the caths. Again, the etiology can be very varied, but again, as I'd mentioned, bacterial endocarditis, more propensity to form constriction. Autoimmune disease, more tendency to form constriction. Again, recurrent pericarditis, you are more likely to see constriction. The symptoms you all know, the signs you all know. So as I mentioned, this does not. Now, is it always very necessary to have the respiratory variation that you see with constriction? No. If you have very high filling pressures, you're not going to see respiratory variation. You will have to do preload, maneuvers to decrease the preload to be able to show the respiratory variation, and that's something that is important to keep in mind. So it is a very high index of clinical suspicion. Patient comes in with significant dyspnea, significant lower extremity edema, and then you have to correlate it whether you should look for constriction. Now, what are the other things that can give you respiratory variation, COPD, RV infarct? We all have seen it in lab, that there is a respiratory variation that is not been explained. But these are the things that can cause it. So again, this is the case that a patient, a lady with chronic recurrent pancreatitis who presented, gets an echo, is short of breath, has leg edema, and this is what we see. So you can see a little, from echo standpoint, we would call this, oh, I think the pericardium is a little thickened. Now, is it an absolute certain diagnosis? No. What you do see here is a subtle septal bounce, and this space looks thickened. This is where I think MR would be, you see respiratory variation, that helps. We didn't have a good view here. And one of the things, this is from a different patient, but what you look for is IVC plethora, IVC collapse, and if you put a respiratometer, you would like to see expiratory reversal in the flow with expiration in the IVC. I will skip through this. Every time you see a septal bounce, is it always related to constriction? This is a case that shows that it could be related to something else. 23-year-old gentleman with cystic fibrosis, and you feel that you're seeing a little bit what looks like a septal bounce here. Sorry, no, this was a different case. This is a case with septal bounce. Anyone who wants to take this? Forget what I mentioned about the clinical history. This is not that patient. Again, you can see there's a collection anterior to the RV. This is a huge hematoma causing constrictive physiology. Again, you can see collection here. You can see a little subtle septal bounce, respiratory variation, LV outflow variation. So it's again, constrictive, diagnosis of constrictive pericarditis remains challenging. You have to have high index of clinical suspicion and no single diagnostic approach. You have to kind of tailor it to the patient. But echo certainly remains the bread and butter first diagnostic imaging study that you're going to do, because it helps you assess and rule out several other things as listed here. And you definitely can show beautiful ventricular interdependence nicely on echo, but so can you on MRI. Some of the features that we have seen of constriction are thickened pericardium, as I mentioned, dilated IVC, flattening of the LV posterior wall in diastole, and then the Doppler findings. And these are some of the characteristic M-mode findings. But when you're imaging for constriction, really we rely on the sonographer to, if there's not an obvious effusion present, for them to be able to detect that yes, there is a little subtle septal bounce, so we should be doing the respiratometer and all the Doppler findings as listed. Because sometimes you end up seeing the study, but then you don't have the respiratory variation or Doppler data that you're looking for. So septal bounce remains one of the diagnostic echo features. It's very specific, but not very sensitive. And this was one patient where I felt there was a diastolic septal bounce. You can see, again, this is the case I was mentioning, 23-year-old guy with cystic fibrosis, has a beautiful diastolic septal bounce, but did not have anything wrong with his pericardium. And he didn't have much, and I'll show you, oh, come on. Okay, I'll go on to the next. And this is his IVC, beautifully collapses, very nice pressures. So this was just a diastolic septal bounce seen with the constriction. There is a role of additional imaging in constriction pericarditis, and there is this table here. But I think at this point I'll end and let Faisal take over. Is he here? Oh, okay, then I'll go through this. So, if it is, you have your characteristic EKG findings, chest X-ray, you look for the eggshell pericardial calcification. You have good clinical evidence on echo with respirometer. and then patient has symptoms, you don't need any more studies. When does additional imaging play a role? When you're not going to just treat medically and you're going to go for surgery, you definitely need CT. You need CT because it is going to help define the anatomy of your pericardium and the calcification very well. This is a very messy surgery. The more information you have, the better. So that's definitely where you want a CT. CT calcification is very well seen.
Glad we had the echo portion done. I'm going to talk about CT and CMR for pericardial disease. And let's begin. So there are a bunch of applications for these techniques in the different pericardial disease states. You heard about the use of echo for some of these, and I'll show you how CT and CMR can add value. So we've heard about, I'll just kind of get going here. Echo is the first-line test for pericardial diseases. However, we know there are patient populations where sometimes imaging with echo can be difficult. These may be patients who have limited views, people who have technical difficulties due to COPD, getting proper windows. Assessment of the pericardium itself, just the anatomy, can be very hard with transthoracic echo. And a lot of that is because of the poor tissue characterization with the technique. And then finally, of course, if you have loculated effusion, sometimes that can be difficult with echo. You really are not seeing the entire heart, and that's where these other techniques can be helpful. So what is it about CT and CMR that can help in this disease process? Well, first of all, both of these techniques have very high spatial resolution. And therefore, as a result, they really have excellent delineation of the pericardium and its anatomy. And therefore, you can very accurately localize and characterize various pericardial lesions. And then this includes any thickening, calcification, or masses. These techniques all have large field of views, and therefore you're able to examine the entire chest at the same time. A lot of disease processes involve the thorax and then involve the pericardium, and so you'd be able to identify these. They also, because of the large field of view, you really have no difficulty differentiating between pericardial and pleural effusions. And determining a loculated effusion is actually very, very easy. Some techniques like cardiac MRI have much superior soft tissue characterization, much greater than CT, and therefore all of this just helps you characterize what you're seeing better. Techniques such as CMR as opposed to CT also have a much higher temporal resolution. This allows you to detect some of the rapid hemodynamic processes that you are used to seeing with echocardiography, and specifically the septal motion, the septal motion that you often see in constrictive pericarditis. And then finally, in some disease states such as constriction and pericardial masses and cysts, you need tissue characterization, and I will be going a little bit more into this. Tissue characterization specifically for determining inflammation. There are pericardial disease states where you can actually reverse the constrictive physiology if you treat the inflammation. And then, of course, to identify masses, whether these are truly benign or whether these are a worrisome lesion. So, and in the next few slides, I'll get into that. So the way I kind of structured my talk is, with these multimodality imaging tests, you should know they are complementary to echocardiography. Usually, you want to choose the test really based on the clinical context, and the way I've kind of divided this talk is really talking about the clinical condition first, and then discussing what each modality provides to it. And really, you should know that the modern approach, or the approach you guys do every day, is really integration sometimes of different imaging modalities to help you improve both the accuracy of what you're diagnosing and then also to help you manage these patients. So so just to kind of create a steady, an even baseline, we have to talk a little bit about what's normal. So here's a lot of information on this slide. A couple of things I'd like to point out. You can image the pericardium both with and without contrast. So here on the right side of the screen, you'll see a non-contrast CT. Generally, I wouldn't, this is not a calcium score. We would want to know that you guys are ordering a scan specifically looking at the pericardium. And the reason is we would make thin cuts, of the heart. So this pericardium can be very thin, and you want to actually get you don't want any partial voluming. So we would make a series of thin cut CTs, but it can be done without contrast. And as you can see, it's this like very thin, curvilinear membrane that you see just right outside of the heart, and that's the pericardium. Generally, you'll notice it's often difficult to see posteriorly and inferiorly, and the reason for that is there's a lot more epicardial fat here anteriorly, and so that creates a very natural contrast for you to be able to see the pericardium, where there's a paucity of that in the inferior infralateral walls. Here are the same images. Once you give the patient contrast, you can again see this very fine, thin pericardium just right outside the myocardial walls, sitting on top of some epicardial fat. You can obviously look at the pericardium in all the different images. Since these are usually isotropic voxels, you can look at these the pericardium in whichever views you're most accustomed to. We have the traditional CT views, which are axial, sagittal, coronal, or you can convert it to the traditional echocardiographic views. Now, one of the advantages of CT for the pericardium, of course, is it's the technique with the highest spatial resolution, so therefore you'll get very pristine images, very clear images of the pericardium. It's very fast. This is a technique that, in one breath hold can be completed, and therefore if you have an unstable patient or you need data rather quickly, this would be the test to go to. And then calcium, as I'll soon show you, is really another advantage if you need to see calcium in the pericardium, which often can be very specific for constrictive pericarditis. CT sees calcium very well. Now, just going back a little bit on the pericardium, I should mention here that the pericardium normally is a very, very thin structure, just like you're seeing. You probably having difficulty seeing it from back there, but it is less than 2 millimeters on a normal pericardium by CT. Now, here's just an example of when, and then you'll see a lot more of these, when the pericardium goes wrong. This on the image on the right, you'll see this is what pericardial effusion. You just kind of get used to kind of seeing these, and it becomes very easy once you've seen one or two. This pericardium is not thick. Compare that to this image over here, where you kind of see this rind. That's the pericardial thickening, and then you'll see the pericardial fusion underneath it. So this would be, a study that may be consistent with effusive constrictive pericarditis, where you have both a thickening process of the pericardium and an associated effusion. Normally, with both techniques, with both CT and MRI, an abnormal pericardium is a pericardium that's 4 millimeters or thicker. How does the pericardium, okay, and so this is just one more slide showing you how easily with CT you can see pericardium calcification. All this it's a very reflective structure, calcium, and so you can see, you have no, this is obviously an extreme example, but you have really no problem seeing the calcification. But I think this is a nice image just to highlight a very important statement Gopi made, was you can now imagine how this is, this heart is sitting in this solid, rigid structure. And so you can almost imagine that there is no room to expand in a pericardium such as this. And that filling of one structure will occur at the expense of the other. Okay, so what about cardiac MRI? So, sir, yes.
So you have this is a practical clinical scenario. You have a post-op patient not doing too well. You do an echo. You're not sure about effusion. You're concerned with the hematoma rather than diffuse effusion. Images are lousy. You have two options. You have two options. You can do a TE, where you might make a diagnosis. You might still struggle a little bit even with the TE. Or you could take the patient to a scanner and do a quickie non-contrast picture. Which one, if you're rounding, would you choose?
I would choose the non-contrast CT for the reasons you said. Yes, it's faster. Where it would suffer is, yes, tissue characterization maybe a little bit.
But at that point in time, you don't care.
Yeah.
Because if you have a big hematoma compressing the heart, you're going to see it.
With conjunction with
echo. I'm sort of leaning to you because, you know, we always use TE, but even with TEE, sometimes we struggle to really see the whole spatial orientation of a hematoma compressing the heart. And if I can take that patient to the scanner for 5 minutes, because it doesn't take practically nothing, as long as the patient is stable enough to at least go to the front and 9, get a picture, and come back to the ICU, that perhaps might be the, I mentioned that because that's a practical situation. We see that in rounding all the time. And transthoracic echo at the bedside in those patients can struggle at times to give us a clear view of the hematoma, and yet the patient clinically is acting like somebody in tamponade, but you don't see any of the, you know, so that's a scenario that is worth discussing. And you would go for a CT also.
I believe so, sir, yeah. And definitely, like you said, in conjunction with the echo, you know what's sitting there and you can figure it all out. And I think, you know, personally, I think we are, as the talk develops, I hope you'll agree with me, I think we are underusing some of these techniques to help us make the diagnosis of pericardial disease. We deal with large patient populations who have had extensive surgeries in the past. These are the patients who develop these diseases. We have patients who have extensive right heart symptoms. You know, sometimes I don't think it's inappropriate for y'all to go around, you know, to assess the pericardium, make sure the pericardium is, you know, normal or not, or at least keep in your mind that constriction can always be a cause. So what about the pericardium with CMR? Well, pericardium with CMR, I hope these images project well, but really looks no different from what you would see with CT. We generally use a technique called black blood imaging to see the pericardium well, and the reason is the traditional images that you see with FISP, with the chemical shift artifact, can make the pericardium look thicker than it is. So this sequence is actually used. It shows the pericardium is, you know, is thinner than what you would see in the FISP imaging. And here as well, the pericardium generally is less than 2 millimeters. And just like CT, we can create, you know, we can image the pericardium from multiple different views and angles to evaluate the full circumference of the pericardium. In future slides, I'll go ahead and show you what abnormal pericardium looks like with CMR. So like I had said, I was going to discuss just some of the different pericardial disease states similar to Gopi and show how these techniques can be used as a complementary test to echocardiography. So we'll begin. So acute pericarditis, obviously this is a diagnosis that's frequently made on clinical grounds. By no way do I recommend these advanced imaging techniques for this disease state. However, if you look at expert consensus, there are disease states which kind of make sense to me, or when you should maybe consider one of these advanced tests. And that's usually when patients present with high-risk features. Here I've put this red box around it, and I'll show you another slide what we mean specifically by high-risk features, or those who have recurrent intermittent pericarditis or persistent atypical symptoms where you want to assess for, you know, inflammation, or, you know, is really the pericardium the diseased, yes or no. So what are some high-risk features where, you know, the experts feel that, you know, it wouldn't be a bad idea to consider further advanced imaging? And those would be patients who have what they call the major criteria, those who have quite, you know, a good degree of fever, who have a subacute onset, maybe have large pericardial effusions, who present with cardiac tamponade, or who, more traditionally what we're used to, you know, you've put them on therapy and you're not seeing a response. And the reason for choosing these cohort of patients is really you're looking for other causes of, you know, other than typical viral acute pericarditis. And you'd be looking for causes such as malignancy, TB, you know, any penetrating injury to the chest, you know, neoplasms, things like that.
Why pancreatitis?
I imagine, sir, that maybe with pancreatitis you can have pericardial effusions, and maybe that's why you can get some irritation of the heart.
Why additional imaging?
Yeah, that's a great question. Maybe you'll, as a tip-off, you'll see some, inflammation or in the abdomen, and you diagnose pericarditis that way. I'm not sure. But yeah. Okay, so Gopi went over a lot of findings of constrictive pericarditis with echo and 2D Doppler. I won't go over it. It's been discussed, but think of it very simply. If maybe I can maybe say it in another way. You have a very fibrous or calcified sac around the heart. This limits the amount of ventricular filling. As soon as you impair filling of the ventricle, systemic and pulmonary venous pressures will be elevated. So what are we going to do with CT and CMR? Well, with CT and CMR, basically, we're going to look at both anatomy. We're going to try to evaluate what the pericardium looks like, and we're going to look for findings that are consistent with elevated pulmonary and systemic venous pressures, and with CMR specifically look for respiratory ventricular interdependence. So that's kind of what these techniques, how we add value to the other techniques. Now, what's important about what Gopi told y'all was that is true. These are the classic findings, but there are patients, and probably these are vast majority of patients, we kind of start seeing, where these findings unfortunately can be equivocal, and that's where you need further help. Patients with atrial fibrillation, the Doppler kind of becomes problematic. In patients who have mixed constrictive and restrictive disease, yes, maybe rare, probably more associated with radiation disease, but if anywhere we're going to see it, we're going to see it over here. And then those patients who have markedly elevated left atrial pressures as well can kind of blunt some of these traditional findings. So what do the expert consensus recommend a CMR? And so I've kind of again put boxes when they recommend it, and basically they're going to recommend it when the diagnosis is not clear but highly suspected, when your echo is inconclusive. So that would be one area. And then the second area is that if you did make the diagnosis and your CRP or ESR or other traditional markers of inflammation are not elevated, or you started anti-inflammatory therapy and you're not really seeing improvement. If you want to assess inflammation, CMR is a fantastic technique for us to help you determine whether pericardial inflammation is present. And I'll hopefully in the next few slides show you why that is important. Okay. So again, so what exactly are we doing with CT and CMR? And I kind of hinted at this already. First is one is to look at the anatomy. We're looking at the pericardium. We're looking for whether it's calcified. We're looking to see if it's thickened more than 4 millimeters. Remember that the pericardium does not have to be globally involved. You can have localized problems with the pericardium that can cause constriction. And then we're looking at secondary anatomical findings that indicate systemic and pulmonary venous pressures are elevated. So what does that mean? Biatrial enlargement, classically right atrium greater than the left atrium. If you have conical deformity of the ventricle, why? You can imagine if you have a restrained sac that's around the heart is, it kind of takes the shape of that sac. And so, I'll show you pictures where it kind of takes this conical tubular form. If the ventricles look small and underfilled, if you have flattening of the septum, indicating that, filling is occurring at the expense of one ventricle's filling is occurring at the expense of the other. And then again, the secondary, findings of impaired filling, both systemic and pulmonary venous, in showing, do you have pleural effusions? Do you have ascites? Are you seeing right atrial enlargement? Are you seeing dilation of the hepatic veins? Are you seeing hepatosplenomegaly? Have you seen a dilated IVC? Those all go along with impaired diastolic filling. And then finally with CMR, with the actual anatomy, not only can you determine thickness, but you can determine inflammation of the pericardium. Now, CMR, of course, greater than CT has a much higher temporal resolution. remember, on the order of 40 to 50 milliseconds. We have a technique called real-time imaging, and I'll show you some of those imaging, where you can actually see the actual hemodynamic response of this heart to a thickened pericardium, much like you could with transthoracic echo. So we can see some of these things that you have seen with echo, as Gopi demonstrated to you. The diastolic septal bounce, the diastolic restraint where the heart just kind of stops, you know, in the middle of ventricular filling, pericardial tethering, the respiratory ventricular interdependence, and then lack of respirophasic changes in the IVC. So here's a case of a patient who had constrictive pericarditis, 2 different patients, and we'll just kind of walk through it. Here's what a very thickened pericardium looks like. This was a non-contrast CT. This was greater than 4 millimeters thick. Here was a case where you can see this very calcified pericardium. I hope you can appreciate now the conical, you know, this tubular form that the ventricle starts assuming because it's being restricted from its normal morphology by this thick sac that's around it. And then, of course, a lot of the other features that I had mentioned suggesting heart failure, such as dilated atria, the dilated systemic veins, an IVC that's greater than the aortic diameter, you know, reflux of contrast into the IVC and hepatic veins, indicating elevated right atrial pressures. And so a lot of these, you know, we can just quickly identify with CT. CMR similarly can show you, this is a good example here, you can see a 4 millimeter thickening of the pericardium anterolateral to the left ventricle, and also here anteriorly to the left ventricle. Generally, again, a pericardium more than 4 millimeters thick is abnormal. I should note that with CMR, calcium, as you know, CMR images are made by proton imaging, and calcium, as you know, does not have protons. So really, if you see, you know, calcifications per se are not well seen. Sometimes we can infer it when we see this, you know, we see a thickened pericardium with a lot of signal dropout. We suspect that there's calcium there, but, you know, it's not that we actually see the calcium as we do with CT. So now one of the advantages, of course, with CMR, and just to show you, is now you can be able to actually visualize, you know, some of the hemodynamic effects of the thickened pericardium. So here you have the traditional diastolic septal bounce, which is just another manifestation of, you know, one ventricle filling at the expense of the other. Here's the cone-shaped ventricles, the enlarged atria. And then, of course, the classic thing that we all want to identify to give us a lot of confidence in our diagnosis is to show the respirophasic changes in septal motion. So here's, you know, a 4-chamber and a short axis of the heart, and let's just take a look at expiration. You can see that, you know, if you saw these images, this is a very normal-looking septum. However, with inspiration, as you increase flow to the right side of the heart, all of a sudden now, you know, the right ventricle cannot expand. And when it cannot expand, you know, the septum pushes over and filling occurs at the expense of the left ventricle. And that's where you see this bulge in inspiration. You can see the septum here was pointing towards the right, now points towards the left, and you can see that very dramatically here also in the short axis. Now this is shown really nicely with what's called real-time imaging. Here you're just taking a lot of pictures of the heart as the patient is doing their general free breathing. Okay, and what you'll notice is that as the diaphragm drops, again, you'll notice that you know, as the diaphragm drops, means the patient has taken in a deep breath, they have inspired, increased filling occurs on the right side, the pericardial sac does not allow expansion of the right ventricle further, and therefore to continue with RV filling, the septum is pushed towards the left, and that's what you're seeing over here. And then this is just a picture of that frozen and inspiration showing you the flattening of the interventricular septum. And this is one very important point I should point out is this is CMR's equivalent of the respiratory ventricular changes you see in mitral and tricuspid inflow seen by echo Doppler. So the respiratory variation that you see with mitral and tricuspid inflow, this is exactly what's happening to filling seen by cardiac CMR. Is that clear? This is kind of a really, really important point. And then, of course, with CMR, we can do other things. You know, you can look for a dilated IVC that doesn't vary too much with respiration. We can also create what are called tag lines in the myocardium. Think of this similar to echo with strain imaging. The idea being is that you can actually watch the defacing of these tag lines both in systole and diastole. And those patients who have a pericardium that's thick or adherent to the myocardium, you'll see that the tag, you know, that there's this adherence of the pericardium and the myocardium, you know, and they move concordantly. So that's another way, you know, we can verify our diagnosis. With the, you know, although we don't have the sequence here, we're actively trying to get it. If we had real-time phase contrast CMR, we could create, you know, very similar images to the respiratory variations that you see with echo Doppler. We could create a slice location at the mitral leaflet tips and tricuspid leaflet tips and just watch flow. And I hope you'll see we can mimic exactly what you would see with echo Doppler. You'd have the, you know, markedly elevated E, the rapid deceleration time, and then the respiratory variation beat to beat across both mitral and tricuspid valves. Now, there was one study, there have been several studies. This is one study that I'll quote that compared kind of echo findings with CT findings. And I just show this slide because, you know, if you look at some of these CT and MR findings of the pericardial thickness and the abnormal diastolic motion, in this study, it was 100% specific for constrictive pericarditis. So what this shows you is, you know, that classically invasive cardiac catheterization has been the gold standard for this disease state. Now, I'm not saying that in all cases that it's not necessary, but I am saying that in several cases, you know, non-invasive imaging may be able to very accurately make the diagnosis without needing any further invasive test. It's important, as you know, when you think of constriction, always think of restriction as well. They often present very, very similarly clinically. And how can we use non-invasive tests to help tease it out? And this is, I think, where really the strength of CMR is because you can look at the muscle and look at the tissue characteristics of the muscle itself. So this is a case of cardiac amyloid for those of y'all who are now getting pretty good at cardiac MRI. So, you know, in this particular case, there was a concern for constriction, but once you gave the gadolinium and you see this global diffuse hyperenhancement of the myocardium, you know, there's no other disease condition that does this other than amyloid. So, you know, and a lot of the findings that you see, the biatrial enlargement, you know, the small ventricles, here in this particular case could all be explained by restrictive myocardium rather than a constrictive physiology. And so with one test with cardiac MRI, you are evaluating both the pericardium as well as the myocardium. Now, one other strength of CMR in constrictive pericarditis is the ability to look for hyperenhancement. So you'll have to trust me on this, but this is the pericardium right here on the 2D FISP images. And with Delight, and these are the exact same slice location, post-contrast. And I hope what you'll appreciate is that all around this heart, you see this white line or this white rind. This is actually a pericardium. You can actually see it very, very nicely here. This white line represents contrast uptake in the same structure that you see up here, which is the pericardium. So what does this mean? That means, the extravascular space is expanded in the pericardium and it's taking up contrast, right? Or it's taking up gadolinium. So what does this actually mean? Well, there's, we'll come back to this. Well, there was this one study, 25 patients with constrictive pericarditis who all went pericardiectomy following a cardiac MRI. And what they found was in those patients who had delayed hyperenhancement of the pericardium, they saw histologically evidence of active inflammation. They saw fibroblasts, they saw granulation tissue, they saw neovascularization, everything that you think of with active inflammation, they saw in those patients who had hyperenhancement before they went to the OR. And this was another study, also very interesting. These were 29 patients with constrictive pericarditis. They all received anti-inflammatory meds after CMR and were kind of followed to see how they would do. And what they found was that, late gadolinium enhancement, identified late gadolinium enhancement in a thickened pericardium identified with 86% sensitivity and 80% specificity the ability to predict constrictive physiology. 93% of those patients found to have LGE were all in the reversible constrictive pericarditis group. That means if you had patients who had LGE and they were treated with anti-inflammatories, in this trial, 93% of them had reversible physiology. And at the same time, they showed that with therapy, not only did you reverse the physiology, but they also showed reductions in CRP and ESR. And going back to this slide, this patient, before anti-inflammatory, this hyperenhancement was identified. This patient was started on, anti-inflammatories with aspirin and colchicine, NSAIDs and colchicine. And here was his CMR 6 months after treatment of anti-inflammatory. I know it may be hard to see, but I hope just a quick look here, I can convince you that this white rind, which I believe to be hyperenhancement, you don't see any further on these images. So this was a case where you can very actively, if a pericardium is inflamed, you have therapies that can reduce the inflammation in the pericardium, therefore improving its compliance, and therefore hopefully reducing constrictive physiology and the patient's symptomatology. And believe it or not, I put this slide up just to remind myself that you can actually see pericardial hyperenhancement with CT. It turns out that iodine has very much the same redistribution properties such as gadolinium. So I just a reminder to myself that if I do a thickened pericardium, if I see contrast uptake, this also represents hyperenhancement by CT. In constrictive pericarditis, CT can be helpful. Sometimes these patients have grafts. We can visualize those. We can tell the surgeon, how closely these grafts are adherent to the sternum. So when they incise, they don't, sever a graft. We can, identify, of course, coronary blockages. We can, if this radiation was the cause, we could look for associated lung injury. But actually, we can help localize the disease and help the surgeons plan their surgical approach. My understanding is if there's a lot of calcification, especially posterior and posterolaterally, it actually changes the way the surgeon does the surgery. They actually do bilateral thoracotomies. And then, of course, here's another way we can keep our patients out of the cath lab, that if this is a low to intermediate risk patient, we can, of course, evaluate the coronary arteries, and if they don't have stenosis, they don't need an invasive angiogram. Wow, 1:15. Should I keep going? Yes? Highlights. Okay, so believe it or not, with these techniques, we can kind of help characterize pericardial effusions a little bit. With CT, Obviously, one, we can determine loculation very easily. We have a large field of view. With CT, based on the Hounsfield units, we can kind of tell whether something is transitive, which generally have Hounsfield units closer to water, 0 to 20, whereas exudative lesions have more protein in it and therefore a higher Hounsfield units. Similarly, we can do that with CMR as well. Transudates generally tend to have a high T1, a low T1 and a high T2 signal. Whereas with exudates, the more protein they have, their T1 signal gets brighter. In general, I don't recommend CCT-CMR for pericardial tamponade. However, as an imager, I do have to know how to diagnose these conditions if I do see a case of that. And so, we have ways with CT and CMR to help us figure that out. When it comes to, you should know that when it comes to mass assessments, these are the only techniques that I would highly recommend. And the reason is because of tissue characteristics. What do I mean by masses? I mean cysts, hematomas, benign or malignant neoplasms. With CMR, we have a bunch of sequences that help us to figure out, what the tissue characteristics of the mass is, and therefore create a strong differential diagnosis. For example, in this cyst case, there's particular ways cysts behave in different sequences. With CT, similarly, we can identify the cysts very easily. Cysts generally tend to have water attenuation. So, if by CT Hounsfield units, if you have a structure that has attenuation between 0 and 20, usually at the right claustrophrenic border, these are more likely consistent with cysts. And then, as with any cardiac tumor, pericardiac tumor, benign, if you're going to have a tumor, benign tumors include lipomas, teratomas, fibromas. We can help identify those. Pericardial masses are probably the most common. They tend to arise from the lungs, the breast tissue, as well as renal primaries. They can spread by direct extension, hematogenous, or lymphatic pathways. In general, if you have a pericardial myocardial metastases, this is usually a late presentation of the disease and tends to portend a very poor prognosis. And this is just an example of that, how with the large field of view, you can see this large lung mass and actually extending into the pericardium with an associated pericardial effusion. And in this particular case, you have this mass that's actually just occupying the entire anterior pericardial space. So it was a pleasure talking to you, and hopefully we can all do this once again.